about the less discussed topic about the ligaments, that is the posterior cruciate ligament. We all talk about ACL, meniscus all the time, but PCL is a no-touch zone. Something we all refrain from entering into. We'll discuss and have an interactive session. I don't want it to be a boring one-way lecture. We'll discuss and we'll focus mainly on the practical problems that we face and the practical tips rather than the theory. Theory, every one of us can read in the books. We'll focus essentially on the practical aspect of the diagnosis and the management. So starting with the slides. Starting with slides, we are all aware of the basic four ligaments of the knee, the ACL, PCL, MCL, and the LCL, the standard four ligaments. These cut sections of the specimen show the insertion origin and the insertion of the ACL. If we look at the femoral aspect on the middle femoral condyle, it is pretty close to the articular cartilage on the femoral condyle. That is the key in all the PCL reconstructions. You have to stay as close to the articular cartilage. So far as the tibial insertion is concerned, it goes way down the articular cartilage level. That is just above the popliteus. These two things need to be kept in mind whenever we think about doing a PCL. So let's go with the acute presentation. A patient presents to you with an injury to the knee, maybe a dashboard, maybe a falling, maybe a jumping, running, sports, whatever. So how do we diagnose a PCL? That is the biggest basic enigma. It took me 2 years to be confident enough to be sure about whether it's a PCL diagnosis or not. So first thing is the history. How did the injury occur? We always undermine its importance. If we talk about the PCL, the most common mode is a road traffic accident. It is not more commonly a sports injury. It's more commonly a traffic accident injury, and generally a dashboard injury. Dashboard hits the knee. Hemarthrosis is a very misleading thing in PCL. PCL generally gets injured from the tibial insertion, and hemarthrosis is not very significant, unlike all other knee injuries. It is a delayed appearance and lesser intensity. For that matter, in around 3 days after the injury, we have a bruising or a hematoma in the popliteal fossa, which is much more consistent feature than actually the hemarthrosis. So within 72 hours, we need to definitely 101% re-examine the patient, check for his pulses, arteries, and neurological status. These are the more important things with PCL, plus the anterior injury of direct impact. These are the two important aspects in diagnosis of PCL. Secondly, one thing I want to emphasize is in an acute injury, we have to tell our residents, if there is a swelling, there has to be an injury. Whenever a tissue is torn, it leads to bleeding, whether it's skin, whether it's any tissue, a bone fracture, anything that breaks will bleed. And any bleeding will be visible as a swelling. So if you have a swelling anywhere in the body after injury, there is a tear, something has been torn. Whether it is important or not is different, but something has been injured. If there is a swelling, that thing we have to always remember. So in case an X-ray shows no fracture and there is a hemarthrosis or there is a swelling, we should be aware that there is some soft tissue injury inside the knee, be it a ligament, be it a meniscus or anything. On X-ray, we can see a posterior subluxation, plus look for associated injuries. These are the basic acute presentation things that we need to see. History, the clinical examination, the X-rays, and look for associated injuries. Dashboard injury, as we all understand, the knee hits the dashboard and is pushed back and generally leads to the tearing of the PCL. The tibia is pushed backwards. Associated injuries. There are three main categories. One are the multi-ligament injuries. Most common association is with the posterior lateral corner, that is the LCL and the popliteus. The biggest 40% chunk of failure of PCL reconstructions are due to missing out on the associated injuries. We fail to recognize them, and that is what leads to overstrain and leads to failure. So PLC injuries definitely have to be looked forward for. And second association is with ACL tears. One association that is relatively important and not so common is bony injuries. Anteromedial rim fractures of the proximal tibia. It is basically an opposite direction of the posterior lateral corner, diametrically opposite. The femoral condyle rubs on the tibial condyle and causes a chip avulsion fracture of this part of the tibial rim. And this is pretty significant. In some patients, a big chunk, and we actually have ended up fixing in 2 of the patients. We did a plating of the anterior middle rim along with the PCL reconstruction to attain that stability. And lastly, as we all are worried about, is the vascular injury. So there's a line which has come on screen. Hello? Now how to diagnose? There's a line which has come on screen. Is it from your end, Desh?
No, sir.
Forget it. How to diagnose is the another question. The diagnosis of PCL injury is essentially clinical. Be it a chronic injury, be it acute injury, we have to understand it is not an MRI diagnosis. It is never an arthroscopic diagnosis. The difference between an ACL and a PCL injury is that ACL is diagnosed clinically as well as MRI as well as confirmed by arthroscopy, whereas PCL is primarily a clinical OPD diagnosis. You have to make your mind inside your OPD that it's a PCL injury or not. You cannot go and take it in the OT and then find out. Most important is clinical. 2 important tests are the posterior draw test and the posterior sag test. One other test is the tibial step-off test, which I failed to mention. These are the 3 essential tests that give you the maximum information. There is reverse pivot shift and all that for dial and other thing, but these are the 3 important tests. Then comes the posterior lateral corner that is associated. For that, we do the dial test and the reverse pivot shift. Dial test at 30° positive, PLC injury. At 90° positive, PLC plus PCL injury. We need to learn these 4 tests, how to do them. Dial, posterior draw, posterior sag, and tibial step off to diagnose a PCL injury. X-ray, as I've told you, to look for other bone injury, conditions, and other rim fractures, we need to have an X-ray. MRI. Never ever rely on the MRI report. Look at MRI films by yourself. Learn to see an MRI. As an arthroscopy surgeon, as an orthopedic surgeon, you need to know how to see your spine MRIs, your knee MRIs, your basic hip MRI, and shoulder MRI. These 4 MRIs, you need to know how to look at them, read about them, take a textbook, but know how to read your MRI films. Don't rely upon the MRI report. Most of the PCLs I have operated have not given a proper diagnosis of these. Next is the arthroscopy. I'll go about it further. This is a very big enigma, how to diagnose PCL injury on arthroscopy. Just need to mute somebody. Disturbance. Hello? Next is... Hello? Hello?
Yes, sir. Now it is clear. Now continue. We have already muted everyone.
Okay. Arthroscopy, very good for ACL, but not that reliable for PCL. I'll tell you how. I'll come forward. Examination under anesthesia remains essential to all these tests need to be done again under anesthesia. Most reliable for me in the OPD setting, frankly, is basically a stress X-ray. Getting a stress X-ray done in the X-ray room or examination under CAM. That is a dynamic way of doing a stress X-ray, and that gives me the best and the most reliable real-time image. I always do examination under CAM for OPD diagnosis, not for treatment, for multi-ligament cases and PCL. I always do it. This is a tip that will help you a long way. Takes some time, 5-10 minutes extra, but it really is reliable. Posterior sag, everybody knows, place both the knees at the same angle, 90°, and you'll see the sag on the affected knee compared to the opposite side. Very clearly, there's a grade 2 posterior sag. Dial test done at 30° shows PLC injury, 90°. This case, there is only PLC, the dial test not positive as 90°. So it is essentially isolated PLC, not a PCL injury. But we need to do it at both the degrees. We cannot get away doing at just one angle. X-ray. The same patient, extremely important X-rays. This was the X-ray 3 days after the injury. This was the X-ray at 1 month post-injury of the same patient. The patient presented to me at this time at 1 month post-injury. Initially, she showed to an orthopedic surgeon in local. He saw the X-ray, saw a small rim fracture, gave a brace. That's a small rim fracture, nothing to be done. But what essentially he did, miss was that the posterior subluxation of the tibia. You can see a mild posterior subluxation of the tibia compared to the femur in this X-ray along with the anteromedial fracture fragment. Because of this fracture fragment, hemarthrosis would have been there, well explained. There may be telltale sign which can be missed, but this posterior subluxation is something which could have alerted him. 1 month down the lane, this subluxed further. If you see, there is slight lateral subluxation of this tibia, plus there is posterior subluxation of this tibia. It is significant. More than half of the tibia is subluxed posteriorly. This was a pretty challenging case, and the biggest challenge was the knee was not free. The range of motion was not good. It was hardly 60-70 because she was essentially immobilized. So I mobilized her for a week. She got it to around 90, but I wanted to operate her early because of the fear of this getting fixed. I could not afford to get a fixed posterior subluxation. That would have been a disaster for a 20-year-old girl. So I had to intervene early, even though that things are suboptimal. I had a grade 1 or 2 PLC insufficiency, which I decided to defer for the time being in view of the significant subluxation, and decided to take a call on this rim fracture intraoperatively. This is a significant importance on the X-ray that we essentially sometimes miss. That target is just, it's a ligament injury, so X-ray won't help. No, X-ray is an essential tool. Never miss the ABC: history, clinical examination, X-ray, MRI. The sequence should never ever be breached, come what may. The sequence should not. Second is an MRI. What I want to show is that both of them show a posterior subluxation. These are two T2 images. This shows a pretty good mid-substance tear, and this is a very good situation as a surgeon, because when you go inside, you will see a frayed, loose PCL sometimes. This is a very good situation to diagnose. But in this case, there is a fraying of fibers, but essentially you see them in continuity. It's stretching and fraying, intra-substance tear. So when you go inside, you really will see an intact, well-taught PCL, but the knee will be subluxating. So these are the injuries which actually are the dangerous one, where you end up missing the essential element. So MRI can be misleading most of the times, even the images. That is why again and again stress that the most important and reliable for me is examination, dynamic examination under the X-rays. Like for a patient, now how does a patient present to us? For ACL, it's simple. He will have a significant history of instability. For a PCL, instability is not the primary symptom. I have a gastroenterologist working with me in the hospital. He has essentially grade 3 posterior SAG, but he's asymptomatic. We had a long discussion, but he's so happy that his knee is working fine that he doesn't want to get it anything done. So instability, even grade 3 isolated PCL tears is not there. It is not a presenting symptom most of the times. Most common complaint with which the patient comes, because he is come, he must be having something, is the anterior knee pain, that to an exertion or overuse. So they have started a fitness regimen. They've started some running, jumping, jogging, long walk, maybe treadmill, maybe cycling. They start having anterior patellofemoral pain. PCL causes increased stresses inside the knee, patellofemoral compartment and the medial compartment. Between patellofemoral and the medial compartment. Medial compartment issues develop late, very late, when there is significant cartilage damage. The patellofemoral is essentially the presenting complaints. So patient will have an anterior knee pain on exertion, patellofemoral symptoms most of the times for a chronic case. And I would say patients are very tolerant to isolated PCL tears compared to ACL tears, like I told you, my gastroenterologist. And so are the surgeons. They also don't want to touch it. For ACL, everybody wants to jump. Let's do it. For PCL, okay, it's going on. Let's continue. Both patient and the doctors are very tolerant. That's the reason why we end up doing very less of the PCLs. Majority of the PCL tears are grade 1 or 2, and so are not very disabling, and patients keep on continuing. Management. First thing is we have to establish a diagnosis. We have done it right now. Now the question is how to go about it. What exactly is to be done? Now diagnosis clear, we have a PCL insufficiency. One thing, never use a term tear in your OPD practice. Use a term insufficiency, because you have not seen the ligament, you have not seen it torn. You are saying it's insufficient to hold under the physiological working limits. So use a term ACL insufficiency, PCL insufficiency. That makes you more confident and more safe. So what is to be done? This is what my boss used to tell me in postgraduate times. I have learned this dictum and worked on it throughout my career. First thing is, do no further harm. Any surgical, any practice, do no further harm. And this is what my boss used to say. As a surgeon, you know how to operate because you have learned it. You know how to do a DHS, you know how to do a plating or a nailing. But a good surgeon is one who knows when not to operate, which patient is a disaster. You should know when not to keep your knife, and you should be confident enough saying to the patient, I am not going to do it. You want to get it done, it's your wish. Go somewhere else. You should know when not to operate and not burn your fingers. This is what my boss told me like 15 years back, and I still read this line again and again. Whenever in fix, I go by this. Simple grade 2 or 1 or 2 injuries can be managed conservatively. I have managed initially in my initial parts of my PCL working. My tendency was to manage everything conservatively. Any posterior sag manage conservatively. हो जाएगा, चल जाएगा, tolerate कर ले, activity modification हो जाएगी, strengthening of quads and hams. And our patients actually did very well. Lots and lots of study code this that they do very good. But the important part in the conservative management is the neuromuscular control. It is not the instability that is disabling in the ligament injuries, especially posterior cruciates or any fracture recovery. If you see patients recover from a fracture, they are well united, but they are not very confident about walking. Some patients who even have a non-union or a delayed union, but they are very comfortable. So there comes the role of proprioceptive training. So you need to have the joint position sense. Even if you are a fracture surgeon, trauma, or you're doing joints, or you are doing this pediatric ortho, whatever branch you're dealing with of orthopedics, read about it. Proprioceptive training is the biggest challenge in returning to your pre-injury level. It is more important in case of soft tissue injuries, especially ligaments, tendon injuries, vis-a-vis bony injuries, but it really makes a hell lot of difference in getting the patient back to his pre-injury levels. I think in the diagnosis part, we have well established that we are diagnosed. I would like the audience to let's discuss something about the diagnosis and then go further regarding the management, because it's a totally different two parts. Diagnosis of PCL and management of PCL, I think, is a totally different thing. So because the biggest challenge, in fact, I was reading the literature the other day, 15% of the PCLs actually end up getting ACL done falsely. So that high is the rate of misdiagnosis. That is why my focus was to how to correctly diagnose the PCL injury. So any questions? Jayesh, we can unmute the participants, or participant who wants to discuss something can unmute and put forward a question. We have a discussion of 5-7 minutes. Yep. Anybody?
I request respected delegates to unmute if they have any questions, as said by Dr. Siddharth Agarwal on the particular matter, and we can unmute and we can have a discussion on the same.
Can we see the participants?
Is there anything?
Siddharth,
yes,
this
sir.
is Nishit.
Yes, sir. Good morning.
Good morning. How are you?
I'm fine,
nice,
sir.
Nice presentation. Can we see the participants? Is it possible? Or
yes, the participants are there. Dr. Roshan is there.
No, but can we see them here or?
Yes, sir. You can see on the software, I think. Yeah, they're pretty much visible, sir.
You might have to let this go. That is.
So we can, Dr. Nishit sir, sorry to interrupt. We can only have 4 screens at a time. So if you let us know which doctor you want to interact, we can unmute them and have a video call with them.
No, I think that what you have. The one thing I would like to add is the history.
Yes, sir.
Sorry, I joined late, but you know in my practice, I have to, because I get a lot of chronic PCLs.
Yes, sir.
Symptomatic, as you said, that anterior knee pain. The thing is that you have to really scratch the hairs of the patient for the old injury history.
Yes, sir.
Because when you tell them injury means they do not go back before 6 months.
Yeah, sir.
And I have seen the patient after 4, 5, 6 years of the injury.
Exactly. PCL is a very tolerant injury. Patient just keep on walking on them.
No, it's not a tolerant injury. Actually, the tolerance is by the other orthopedic colleagues.
Yeah, sir, you're right.
Yeah,
Yes.
because they have anterior knee pain.
Yeah, sir.
Most of them, they are treated by chondromalacia,
Okay, sir.
and these patients, they get tired, and then developing they get a medial joint line pain.
Yes, sir.
And with this era of joint replacement,
Th-
they are
Then,
चार साल 5 साल निकाल दो, फिर जॉइंट बदल बदल देंगे आपका.
yeah, sir, you are absolutely right. That is the,
बीच में there is no HTO for these
yeah,
patients.
we can offer
So
many things.
I think that we have to, one thing is very certain, that when you have PCL patient and you diagnose a PCL,
Yes, sir.
if you understand, most of the time you can diagnose only by history.
Yeah, history and
Yeah.
examination, I think sufficient.
That is what the history is the male culprit, and I mean history you have to be very good, and that is why you need time for the PCL patient in the consulting room. That is why I think if you have
Yeah,
40-50 patients waiting outside, you will not be able to diagnose PCL usually most
for
of
a
the time.
ligament injury, sir, clinicals is the way to go, sir. I think depending upon MRI doesn't help out. You have to go by clinical judgment, sir.
Absolutely, I think MRI, and especially if you do not, please do not read the reports.
Yes, that is what.
Reports are horrible. I tell you, for the PCL reports are absolute. And I think it's a comma. Usually normal PCL is.
Yeah.
So when you see a stretch PCL or straight PCL,
Yes,
it
sir.
is usually a stretch PCL. And
Yes,
as
sir.
you said that you have to use the term PCL insufficiency,
Yeah, sir.
because that is insufficient PCL. When you see a straight PCL,
Yeah, it is
I think it is the
interpreted
insufficient
insufficient.
PCL.
Yes, sir.
And one more thing, I miss, let other people ask.
Yeah, sir. Please, sir. Anybody? Dr. Inderdeep, Vade, anything?
Sir, there
Sir,
is
not
one
Nishit,
question
you please. Yes,
from
sir.
Roshan Wade.
Yes, sir.
That is PCL instead. Clinical diagnosis and MRI both are sensitive.
Yes, sir. Hello.
Naturally,
This is the comment of
Roshan,
Dr. Roshan.
Sir, MRI is pretty sensitive in diagnosing. Problem is reading of the MRI. If we are good enough and comfortable reading our own MRI, that gives a very good understanding. Problem is many of us are not very comfortable reading the MRIs. They depend upon the reports to corroborate the findings. That is where the problem starts. I do stress examination. That is, getting a stress X-ray is a tedious job. So what I end up doing is I do an examination under C-arm. That is where I actually make the diagnosis of PCL finalized, or a posterolateral corner, or MCL or LCL. All these injuries apart from ACL, I prefer to examine once under C-arm and do a stress examination. That actually gives me a comforting feel that I'm correct. Over and above the history the routine examination and MRI.
Siddharth, I would like to know that you said that PLC, isolated PLC. Do you think isolated PLC is possible?
Isolated PLC is extremely unlikely to happen. Generally, PLC giving a significant feature. It may be associated with grade 1 insufficiency of the PCL. The PCL is not completely torn, but grade 1 or grade 2, which is associated with PLC, or maybe a partial ACL. That is what is generally associated.
That is what I'm saying, that whether it is 90-degree or 30-degree, isolated PLC corner injury,
So
usually
could be
it is
that.
very,
Sir,
very
actually,
difficult.
I didn't have an actual image right now sitting at home, so I took the images from here and there. So I
No, I
could not.
understand.
Yes, sir, I got it. Isolated is very, very rare that you get an isolated PLC. It has to be something associated with it. Minimalistic.
Right.
Yes. So shall we move further, sir?
Yes, yes.
Sir, there is one question.
Yeah, please.
So shall I?
Yeah, Josh, go ahead.
Yes. So there is one question by Dr. Inderdeep Singh.
Yeah.
Doctor is asking that which clinical test is more sensitive, and which position do you prefer to do dial test? I think it should be combination of tests rather than a single test alone.
ID, hi. Yeah. ID is a number, sir. Basically, I feel that the most sensitive test for PCL insufficiency is a tibial step off test. If you keep your hand on the front of the tibia with a metacarpophalangeal joint at the joint level, and we can feel the hyperextension at the joint. This joint is more sensitive to the hyperextension. And if your palm is basically at the tibia tuberosity and your fingers are at the patella, this metacarpophalangeal joint at the joint line, you feel that hyperextending force. That is one of the very sensitive tests if you talk out of all these three. But otherwise, I do a combination of these. So far as PLC test is concerned, essentially it is for the this dial test is for PLC at 30° is what I'm looking at for PLC insufficiency. I don't rely upon the dial test for PCL tear. It is essentially for PLC tear.
No, that's fine. But you
Yeah.
would like to do dial test in a supine or a prone or some other trick for it?
I actually most of the times do it in supine position only. Rarely I do take the patient in prone. But I didn't have the image as I told you right now is available with me. That is what I do.
Yeah,
I do
dial test. This dial test is in prone.
this dial
Okay.
test.
Fine.
Dial test is always in prone.
Of diagnosing
But when you see you want to see the posterior corner insufficiency, then you don't have to make the patient prone all the time.
Yeah, sir. So we
Right.
end up.
You can
we
do,
end up
and before that, I would say that everybody has to do a valgus varus test
yeah, sir.
in full extension and 30 degree before doing the dial test.
Yes, sir. So that gives us an idea about the LCL, and further the posterior lateral corner can be assessed.
Absolutely. So
yes, but sir, you're adding.
And of course, you have to compare both the sides without fail.
I have a point to
and before that, I would always test about the generalized ligament laxity.
Yes, sir, absolutely. This point I forgot to mention. Generalized
ligament laxity means those 9 points. Every orthopedic surgeon or anybody who is doing ligament, we must know these 9 points of examination. I mean, nine points that for the general.
I have a point.
Yes, sir. Yes, sir. Yeah, what is, sir? Dr. Roshan? Sir, you need to unmute your computer, Dr. Roshan.
Or the person who's handling this can do it.
Yeah, sir.
Yeah, I feel whatever you had told just now was regarding PLC. If it is a combination injury, yes, you'll get an PLC, PCL, you will get a dial test positive. But even in isolated PCL, sometimes you can get the varus valgus laxity because PCL, see, remember one thing, PCL is a central stabilizing structure of the knee. It is the most important critical stabilizing structure. The moment you have loss of PCL in any plane because of sagging, your varus valgus laxity test will be positive. So it is very difficult to know. Right? Yeah, valgus also, varus also.
Okay.
Varus is more positive than valgus because PCL.
So it is very difficult to identify the combination of injury unless you do a very, very thorough investigation and thorough examination. Sometimes clinically it's very difficult to pick up whether it is isolated PCL or it is PCL plus PLC. The best way is by doing examination under anesthesia. You can take the patient under examination of anesthesia and document it with radiology, either in the C-arm, and that will give you a complete idea, complete diagnosis of the knee. It has to be supported by your MRI diagnosis. I will not agree with you that you told reading MRI in PCL is very difficult. Rather, reading MRI in PCL is very, very easy. It's a very big ligament. It is vertically oriented ligament, unlike your ACL, which may be missed on MRI. PCL, generally 99% you never miss on MRI. So
absolutely.
MRI is a very diagnostic for PCL, very, very diagnostic, even the changes, because it's a completely vertically oriented ligament. So both your clinical and radiological diagnosis has to match before you plan any surgical contemplation in that patient. So I have point.
I would advise that everybody should, if they are suspecting PCL and the MRI has not come, then at least ask for 3 mm cuts.
And on Siddharth, on your statement which you made that indications to operate PCL, grade 3 PCL, you like to, if you might get a good result with conservative line of management. See, I think
grade 1 and 2 we think about conservative, not grade 3.
So
But only in acute.
We do operative. My
yeah,
gastroenterologist is not willing to get himself.
I think
That
delegates
is the
must
issue
know
with
about
him.
reverse Mackay effect, which is created because of PCL insufficiency.
Inflammation.
Whenever you have a PCL insufficiency, there is a posterior slag, and that posterior slag will increase the patellofemoral joint pressure, and eventually will lead in early patellofemoral arthritis, which is very, very detrimental and difficult to treat. That is the reason why you should treat the PCL
that is
insufficiency. Yeah. So reverse Mackay
exactly,
effect
sir.
is the one
I
which
am very
gives. Hello.
Yes, sir. Please go ahead, sir.
Yeah, the reverse Mackay effect is the one which leads to early arthritis and very dangerous if you leave it alone. So even in grade 2 PCL, if the active patient, younger patient, I will consider partial reconstruction of PCL.
Great, sir. That is what we can call as PCL augmentation. We retain the original remaining
Yes,
PCL, and
yes,
over and above that, we reconstruct a new
yes,
ligament.
yes. Because
So I think
I want to prevent.
Roshan has made a very good point that the reverse Mackay effect is very, very common in this country, and especially when our country is all the people they try to sit on the ground, and at least 80% using Indian toilet. So
Yes,
the
sir.
patellofemoral with the PCL insufficiency, the patellofemoral deterioration is much more faster as compared to Western countries.
Okay. So,
I have a question, Dr. Siddharth, Dr. Inder here.
yeah, ID.
So I just want to talk about something about the X-rays.
Okay.
When we have X-rays and you are planning to do a stress X-ray, so what are the techniques for doing this stress X-ray? Which is the best technique in our hands or in India? Because there are certain devices which are available.
For all practical purposes, our X-rays are done by technicians, and to teach them each and every stress X-ray is very difficult. That is what is emphasized. I prefer to do examination under CM for these patients in OPD itself to do that stress testing rather than giving it to the technician to do X-ray.
Then
So that is we can do the maneuvers of this posterior core and the varus and valgus stress under CM and see their effect on the X-ray rather than sending him for a stress X-ray in different positions like in kneeling down. It's a very difficult scenario to get it done in our setup, Indian scenario, to train your
then
specifically.
how do you grade it? How do you grade the PCL injury, like grade 1, grade 2, and grade 3?
Essentially, it is the
How do you grade it?
posterior subluxation. That is up till 5 mm, more than 5 mm, 5 to 10 or more than 10 mm. That is how great.
So you do it on CM itself?
Yeah, do it on CM itself. It's more of a CM and a clinical diagnosis. I don't actually end up exactly measuring with a scale, but
You take every patient to the OR and do
whichever, apart from the standard ACL and meniscus, any multi-ligament, any varus valgus instability, or any PCL, I take them to the OR and examine under CM. For sure.
ID. It is a very, very valid question what you ask. You know, whenever we are having meeting and presentations, you will see all those fantastically demonstrating the unstable knee where you have posterior subluxation of tibia. Once in a while, you can do that for documentation purpose, but in clinical practice, usually we don't offer stress X-ray for each and every patient. But yes, you can do it. You can do the stress X-ray in kneel down position. You can do it on supine position also. Rob Laprade described the kneel down position where he can put, spacer, and then you can grade it. If the displacement is more than 10 millimeter, it will be grade 2. More than 17 millimeter, it will be called grade 3. And yes, the grading has to be radiological. You cannot do it clinical. But in clinical practice, everybody doesn't do stress X-ray for every PCL. But yes, you have to document it. You can do it.
And
Okay.
it's not a very easy. Either you do it by yourself, not a technician, or you teach your 1 or 2 radiologists how to do it, and they can do it very nicely.
Yes.
That's a good practical tip. Actually, we have to train our technicians to do that.
Absolutely. Or it takes you 5 minutes to go out of means your technician is going to keep everything ready. What you do is that because you need neutral rotation.
Yes,
the
sir.
problem is that most of the time the people are not able to maintain the neutral
What
rotation.
I'm saying, our decision of surgery is based on that specific one examination. That is why in PCL, we don't have PCLs day in and day out, maximum 2 or 3 PCLs a month. But that's what I'm doing, maximum 2 or 3 PCLs a month. So
that is big number, huh? 2-3 PCLs a month is a big number, boss.
Sir, average is 1 to 2.
You have reached an elite group now.
Yeah.
Sheetal is the elite guy. He has taught me PCL and but 1 to 2 PCL तो regular है sir, हो जाता है. So 1 to 2 PCL we can go in the routine. हाँ जी sir.
Problem we get what out of chronic PCLs.
Yes sir.
The acute PCL and the chronic PCL is a very different scenario, you know.
Sir, either way, acute PCL, we are not going to operate unless it's a gross subluxation. We'll have a range of motion. We'll let the knee settle down. So it is essentially the chronic PCL that poses a challenge. It's a grossly subluxation. Yeah, so chronic PCL, we get time to examine. So let's move further, I think, sir.
I want to add one more point of that. Sorry for interruption.
ID, please.
But there are many instances when we see the X-ray and a TPL PCL avulsion, a bony avulsion, is quite often missed by most of the orthopedic surgeons. So we should try to look for it. That's what I want to add. I mean, tibial PCL avulsion is very commonly thing which we find on X-rays in acute injured PCL. I mean, acute knee.
ID, you're bang on the target. I have a part of the presentation PCL avulsion also. We'll discuss about that. And,
sure.
And there comes the role of that hemarthrosis, the first thing that I told. When there is a swelling, if at all there is a swelling in the knee, something has to be injured. You cannot have a normal ligament, normal soft tissue, normal bone, and having a normal knee. Something has to give way to give a swelling. So in case there is a swelling, there has to be some sort of injury, whether a ligament or a soft tissue or a bony avulsion or a fracture. So that is where it comes. You have to search for that. If you are not able to find it, you are missing something. There is where we'll go. Okay. So moving further, I would say we had the MRI diagnosis and I need to, how do we minimize this? Yes, now done. Okay. Chronic cases, we had the patients are very tolerant to this. I do know further on. Yep. The proprioceptive training we were talking, that's a very integral part, which I feel unless we have a proper proprioceptive training, we end up not getting the optimal results. And I think everybody of us would agree with this point about the proprioceptive training, be it any sort of injury. So,
Siddharth, may I ask you, what is the proprioceptive training?
Sir, basically the exercises which help in the proprioceptive stimulation of the.
What do you prescribe?
So I will start with single leg balancing with eyes open and eyes closed. That is where I start. Then I start balancing on an unstable platform on a single leg squat with a ball in the hand, with a hand stretched forward. And when they at 6 months in a single leg hop, basically the physiotherapist has that protocol written with him. And these are 7 or 8 exercises I've enumerated. That is graded upon recovery, but proprioceptive training needs to go in for 1 to 2 years. That is what I personally feel.
How many of our patients will do for 1 year, boss?
Sir, actually,
it's very easy for you and me to say that do it for 1 year. You know, patients, they do not do anything after 3 months.
So cycling they do. Cycling most of the patients continue. Yeah. Proprioceptive training, sir, if they're even 70-80% of the previous proprioception level, that does well for a normal patient. And if it's a sports person, they are motivated enough to continue doing it. In fact, I have videos of my patients doing it at 8 months, at 12 months. I tell them to send me the videos while they're doing it so that references for other patients also develop. So that is something I am very happy with proprioceptive training.
Roshan, what is your thought on this?
Hello, Dr. Roshan?
Roshan, are you there?
I think sir is not around.
Okay. So
hello. Can you hear me?
Yes.
Can you hear me now?
Yes.
Yeah, you are not seen, but you are.
So I think the proprioceptive exercises patient will not do beyond certain point. There is no point in prescribing it for 1 year. They will never do it. The exercises can be done for 1 month, 2 months, 3 months. Beyond that, their patients will go away. What is more important is here is in acute scenario, the evidence that has shown that there could be healing, because PCL is a very big ligament.
Yes,
It's a
sir.
vascular ligament. So healing chances are very, very high in acute scenarios. So whenever you have acute injury,
Are we discussing acute or chronic at this moment?
So either way, we are discussing total PCL.
Okay.
so I think we have to channelize our discussion. I think we are going very heavy. Siddharth, you can finish off your talk, and
Okay.
then we'll sit on. Huh?
Okay.
Yeah, sure,
So,
sure.
Going further, sir, what literature tells us, as we were discussing, there is chances of increased osteoarthritis, or any sort of subluxation, be it grade 1, grade 2, grade 3, will increase the stresses on the anterior compartment and the medial compartment and end up with the increased OA chances. Some studies this tells this to be equivocal, but all of them agree that's a grade 3 injury, or it's a multi-ligament or a combination. Then there will definitely be significant symptoms and articular deterioration, whereas some patients with a single isolated PCL may have asymptomatic path. Otherwise, the natural history again says the same thing, that with individual PCL disruption, they may remain symptom-free, but otherwise, in the patient which are multi-ligament combined instabilities, a less desirable result is there. And the functional result was not due to type of instability per se, but it's due to associated factors. That is the secondary developing thing. Chondromalacia patella, that is the anterior problem, the meniscal derangements, quadriceps atrophy, and degenerative changes. That is what actually is the problem with the PCL injuries. It leads to the early degeneration of the knee, and that is what troubles the patient more than the instability. What I follow in my practice is, number one, a symptomatic patient. Patient has come to me in the OPD because he's having some symptoms. First in priority is symptomatic patient. There's a failed conservative management with grade 1 and grade 2. The patient is not willing to adhere to it. Then in case, or the patient is doing it for the last 3 to 6 months and still not, comfortable with his knee, or there is significant subluxation more than 5 mm, but the key is reducible. The posterior subluxation has to be reducible, or it is a multi-ligament injury. I plan a surgery. I don't go in for conservative and multi-ligament or a grade 2 insufficiency. I do an augmentation in grade 2, but I do it. This is what I follow. What are the absolute contraindications that I want the juniors to do? One is infection or other anesthetic or medical indications, we all understand. Second is restricted range of motion. We need to have minimum 90 degree, preferably 120 degree of comfortable movement. Comfortable movement is the key. Unless our knee is fully extending, it is like if there is FFD of 20 degree, you are in for a disaster day one. You have to have a comfortable free range of motion. Thirdly is irreducible posterior subluxation. This is the biggest challenge that we sometimes encounter, that there is posterior subluxation which has now become irreducible. You are not able to get it to a neutral position. And any sort of PCL or a posterior stabilization is bound to fail over a period of time. When you cannot get it passively to a normal position, your ligament reconstruction is either way going to fail. Or it's a warm or a hot knee, that's an acute scenario, or maybe a reactive knee. There is no fun of operating and getting in trouble. This is something I am very, very particular. I have to sometimes really counsel the patient that we have to wait. I am not going to operate in such a acute knee. I will wait. If you want an early surgery, I cannot offer it, but you have to. Then there is a pre-operative planning. Do see collaterals. I don't remember who told this in which talk, but I ask on. Yet you have to plan before the fixation of ACL or the PCL, whether you want to do a collateral or not. Because after you reconstruct either of the ligament, the laxity will decrease and you will end up making a laxity of which is 2 or 3 plus to 1 or 2 plus. So you will feel that this laxity is now reasonable in limits and we can leave it. So you have to take the decision of doing a collateral ligament reconstruction before you fix your ACL or PCL. Otherwise, you will end up leaving most of collateral ligament injuries. That is one of the very important parts of planning. Maybe you decide it on table just under anesthesia, but make it before you fix your ACL or PCL. ACL integrity, what exactly is there? So you should be sure about whether your ACL is intact or not. Sometimes confusing. And because the posterior correction of the posterior sag sometimes there's a feeling of anterior draw test coming positive. It's a very, very confusing thing. Pivot shift, I feel, is a very good test that helps in such scenario. Rest, we can see the ACL on arthroscopy. We'll discuss further. The choice of graft, especially in multi-ligament, we have to plan perioperative, whether you want a contralateral hamstrings, whether you want a BPT or a peroneus longus. I use it quite common. I think Dr. Nishit must be using, Mancha told us. CQT is another option, but we have to be very clear about our choice of ligament, well discussed with the patient. And last is tourniquet time management. One of the very big stress raising factor. How much tourniquet time do you want? Whether you want it deflated in between or what? I have a tip with somebody, which I got it from Sheetal, I think. I was advised, take your graft without tourniquet. So utilize that half an hour, 40, you're going to take 2 or 3 grafts. So once you're done with your scopy without tourniquet, just do a diagnostic around 5-7 minutes without tourniquet. Then take your grafts, prepare them. You end up saving good 45 minutes of tourniquet time. That is something which will decrease the load of your mind. You can do then 1 hour of tourniquet surgery and get it deflated. So tourniquet time management is one of the very essentials of a multi-ligament injury, which is more often scenario in PCL injuries. Instruments, you should be very, very, very comfortable with your PCL instruments. Don't change them again and again. Take a company, fix it up. If you want to try an instrument, keep your old instrument on the table as a backup. PCL instrumentation, they are like your hands. If you are not comfortable with an instrument, you are gonna mess up on the table. This is the PCL femoral jig I'm using. This is a PCL tibial jig. This is the part that goes way down on the posterior part of the posterior aspect of the tibia. These are the markings of this is a 20 mm line. And this is the wire catcher, the instrument I just love, and I just don't understand, I cannot do a surgery without this. I have not found this in 1 or 2 instrument kits. So that after that, I made it sure that I have my comfortable instruments on table, whichever instrument company I may use. Surface marking, desirable always to do a surface marking. Sometimes we do jump over and skip it, but it makes your life many times much easier. This was contributed by by Nitin, one of my friends. I didn't have the all images ready with me this time. And then there is an intraoperative arthroscopic picture. What does it look like? Unless it is a gross PCL damage, major damage, the picture is more or less confusing. Femoral origin, majority is intact. Injuries at a tibial insertion. So it is not really identified. For that matter, I remember 1 or 2 cases in the initial part when I started doing PCL. I just could not figure out whether the PCL is actually injured or not, because I just found a taut ligament going from the femoral right down till the back of the knee, and I just could not make sure that it's a torn PCL or not. I have 2 or 3 tips for that. One is you have to pre-operative sure whether you want to go ahead with the reconstruction or not. Second thing, reduce the knee, give an anterior drawer force. Your ACL will become taut. Then you can make a better decision about the PCL insufficiency. And lastly, the actual correct diagnostic feature is go from the posterior medial portal, clear up the posterior fossa, look at the PCL area, and then you can be much more sure whether your PCL is insufficient or not. But arthroscopic diagnosis and deciding whether you want to do a PCL or not is not a very, very comfortable scenario. So you should be reasonably sure in your mind before you go in. One thing that all of us encounter, and it is very, very difficult initially is a sloppy ACL. Be sure you're identified. I was reading the literature yesterday that said that 15% of the patient end up getting a falsely ACL done. 15%. That is a huge number. Well, but otherwise you will end up cutting the ACL. So what I do, I check the ACL after giving anterior drawer force. Secondly, I try a pivot shift. In my experience, I find that pivot shift comes negative in case there is a ACL is intact. Be it a sloppy ACL, be it a PCL. That is the thing I rely a lot on intraoperative to be sure whether this is an intact ACL and torn PCL. This is a sloppy ACL sign. If you see, this is many times you see the picture. We can have a look. This PCL essentially looks okay. This synovial fold, even though it's not cleared up, and the ACL looks not okay. So this is what is really confusing for the youngsters. Be very, very sure that it is not a ACL tear, it's a PCL tear. Do not miss this sign. Do not take this sign lightly. Technique, pearls and pitfalls. One thing you just need two posterior portals. You need basically one is visualization, one is instrumentation posterior. Otherwise, you can have one posterior portal for instrumentation and a 70-degree scope for visualization from the interior part. It's a luxury which most of us don't have. At least I don't have. So you need two access on the posterior parts. Some surgeons I know differ. Dr. Nishit once guided me that with time you get so comfortable that you are able to do it from interior. But for starters, you need two posterior access, one for visualization and one for instrumentation to make your life comfortable. Otherwise, you'll be struggling throughout the case. You'll either make a tunnel which is not so inferior, or hanky-panky something or other is very risky. You need two posterior access. This is the case of two portals being posterior. One is on this one is the posterior medial portal. This one is a posterior lateral portal. There's a Visinger rod going through and through. Looks very scary at the first onset. I felt very scared when I made this initially. This was this technique basically Mancha uses in all his life surgeries. So I had discussed it once, twice, thrice before I actually ventured into this. But once I started, it was very comfortable. It really makes your life very, very easy. Going with this type of technique, looking from one side, and that through and through access is very comfortable. You need to. Otherwise, the other technique which I actually practice most commonly, used to practice, is two posterior medial portals. One is high and one is low. The disadvantage with this technique of two is you sometimes lose the track of the midline, because after debriding the septum, you don't really sometimes realize where is the midline, and you go very close to the artery posteriorly. That is the very big flaw of this type of technique which I felt. So this is much safer, the two posterior medial thing. In this, you never lose the track of the midline, and you rarely end up going near to the artery. So these are, but essentially you need two portals. The disadvantage with two posterior medial portals is that there is a lot of crowding on the posterior medial surface. But yes, you need to access. This is a demonstration of the posterior medial portal. There's the posterior medial capsule, and there's this spinal coming behind the medial femoral condyle. There is a tip which I need to tell you. I ended up damaging my scope because of this fault of mine. You need good posterior medial clearance to work externally. Your knee should be hanging right off the table. You should have good amount of thigh which is visible to you. And there should be no sheet or draping interfering in the posterior medial region between the perineum and the knee, so that you can take your hand, you can take your scope, your wires there. Otherwise, the sheets keep on pushing your hand, and you end up putting too much stress on your instruments, and you're not able to actually get a good posterior medial clearance. So I make sure I do my positioning and draping all by myself in all my PCL, so that this posterior medial clearance is good enough, so that I have a lot of posterior working space externally, not the inside. Externally, I need space for my instruments to handle. So that leg is hanging maximum of the table and normal leg is far off, so that middle space is all opened up. Technique. There are two techniques for PCL reconstruction. One is the on-inlay technique on the tibal side, and other is the arthroscopic all tunnels technique. Literature has essentially said no differences in the two. The results are essentially similar. I was comparing the studies. So whichever you are comfortable with, whether opening up and doing a tibal inlay on the side, or going in with a transtibal tunnel technique. Another thing I forgot to mention is the technique, that is whether you use a all inside technique or a fixation with a screw. I personally have switched my techniques a lot to all inside, especially in PCL, because I feel more secure and I'm able to give more turns to my ligament and make it thicker compared to the other way, the standard tunnel technique. So I feel that we can think about all inside technique for PCLs, giving a better, thicker ligament and a more secure hold on both the tibia and the femoral side. I make femoral tunnels first, whether it's inside out or outside in is irrespective, but I make femoral tunnel first. The key point is on the femoral tunnel side that it has to be as close to articular cartilage. That is the first slide I showed, the origin of the PCL. So it has to be close to cartilage. The superior inferior extent is important, but it is important to a lesser extent. More important is the closeness to the articular cartilage. It has to be as anterior. Either way, the direction of the pull is gonna pull it posteriorly. So err on the anterior side. Outside in, you can make it, you have to make it with a jig. Generally it is 25-28 mm. We prefer a fixation by a screw because a small tunnel button is difficult to hold on to. Advantage is good hold of screw in the bone and less acute angle of the tunnel. Disadvantage, you need a femoral jig which is less familiar to use. More chance of graft laceration with a screw. Femoral bone is a very hard bone. If in case you have a tunnel of 9, you have to use a screw of 8. You cannot end up using a screw of 9 or 10. You are bound to have a graft laceration. So that is one thing which just doesn't fit in easily initially. And another thing is you need to have anterior middle skin incision to put a screw. These are a few disadvantages, but I feel it is a pretty good technique. I started with this. You have to put that jig. We can put it slightly more anteriorly rather than what this is still 7 mm off. I prefer like maybe 5 mm off from the articular cartilage. Then the guide wire coming in and stopping the guide wire by accurate and making the hole. If you see, I have still 2 mm of bridge left, which normally I tend to cover up by making it further more anterior. Inside out. It's made very much like an ACL tunnel. I do it in 90-degree knee flexion, no further flexion. I got it to get a tunnel of 35 to 40. You can use a button. I prefer adjustable loop because I am more of doing of this all inside technique. Advantage is a more familiar way. Disadvantage is that angle becomes slightly more acute compared to the outside in technique. Tibial tunnel is the key and it is the challenge. I make it after the femoral tunnel. There's a reason behind it. Otherwise, we all feel that the difficult part should be done first. My reason of doing it at the end is that as soon as I'm through with the tibial tunnel making, I just want to pass my graft before the debris, before the soft tissue gets swollen up and obliterate the aperture. I just want to be through with the passing of the graft as soon as I make the tunnel and have the good vision. That is why I make it in the end, and immediately after that, I just want to pass my graft. So tibial tunnel, everybody knows, we have to go as inferior as possible. This is the popliteal fibers here, and it is basically as like 15 to 20 mm below the joint line. You can take off the arm if you're not comfortable at the end, but this is the key to your success. There's a diagrammatic representation. Place the jig inferior to the articular surface, drill it with the drill the tibial cortex. Last part of the cortex, you can do a hand reaming so that it does not overshoot, and then you can do a reaming also the last part again by hand reaming. Then you can pass the graft. Drilling under C-arm. This is the jig, which is this is essentially the wire catcher actually, which is holding the guide. This is the wire catcher which is coming, holding the wire in the cup, and this is the guide wire which is coming. This is a C-arm image I specifically, purposefully put to emphasize the importance. Once we are through with the femoral tunnel making, the tibial tunnel making, then it is the passing of the graft and fixation. Essentially, there is no superiority, all the studies have stated, of any fixation method or over the other. Whether femoral screw outside in, inside out, or the button fixation, or a staple fixation. Staple I've never done, is a critical part for me. Or in the tibial side, you take the screw fixation, or you fix it on the post, or a button, whichever you use, essentially, or an inlay technique. They have not shown any superiority as of now. This is the same patient. This is one of my patient which is very close to my heart. So I end up keeping these pictures again and again. This is the 1 month post injury, the anterior medial rim fracture with a PCL insufficiency, the posterior sublux knee well reducible, grade 1 to 2 posterior lateral laxity was there, but I decided against doing a posterior lateral corner because the knee was not so silent and I was really skeptical. This is immediate post-op. This is the tibial tunnel, right inferior. This is the button, right up. And this is, I think, 4 months post follow-up. The knee is still holding well in position. Maybe there is slight posterior subluxation compared to the immediate post-op X-ray? Maybe, but patient is pretty happy. I'm happy. This is what it looks like. Now the dangerous zone, the one thing which we are always and always away. Frankly admitting, I've had an arterial injury, so I've burnt my fingers badly, and now I know what not to do. Tibial tunnel is the danger zone. Stay away from the artery is the key. Just stay away. Read your anatomy. Do your workup. Do your homework. See your images on the atlas. See your scans. Learn where the artery lies. Read normal CT angios. It is just posterior to the posterior horn of lateral meniscus. And frankly speaking, when the knee is extended, it is very, very close to the capsule. In flex knee, still you have 1.2 centimeters margin. In extended knee, it is just abutting it. So we have to know the position of the artery, read it, have the images stick on the your X-ray board so that you don't end up making mistake. Tips. The biggest tip which I feel is that shaver tip should always be directed towards the tibia. Should never ever be towards the capsule, even superior. Just directed towards the tibia. Use a periosteum, use a blunt dissection if you are not comfortable, but don't end up doing this other way around. This is the mistake I made. My shaver lacerated the artery in that case. Never cross the midline. If possible, try to, not cross the midline. Midline is a watershed line. Your ligament may actually end up being slightly on the medial side. So slightly on the midline or just medial. It is still giving you very good stability, but trying to go lateral, you may be crossing a danger zone. So never cross the midline. Another thing, difficult to apply because it's a dynamic thing. Somebody applies an anterior drawer force to your leg so that the space is opened up. Use a wire catcher. The instrument I showed, the accurate type of instrument, this one. Always this instrument, this one. Always use such sort of instrument which has a hole for the wire to stay in it. The wire does not overshoot. You have to have something like this, accurate type of instrument which does not let it go. And do not do anything without visualization. This is not ACL. You even 2 seconds of doing it blind and you can end up in a disaster. You don't see, you stop. Whichever step you are, you just stop there and then. Unless you are seeing what you're doing, just do not do it. You have to stop. What is the most common way of the popliteal artery injury? Whether it's a guide wire tip overshooting, or it is a reamer overshooting, or it is a shaver blade. We are often, we understand that it's a guide wire. You have to be particular about guide wire. Just make sure. What I practice, we have 2 types. So one is the drill type of guide wire, and one is trocar tip, just like a K wire. I prefer a K wire tip of guide wire while doing a PCL, so that if at all it overshoots, it does not tangle around the tissues around it. It can puncture, but it will not tangle. The drill type of guide wire has a tendency to wrap tissues around it. So this is what I've changed in my practice. A reamer, generally you don't overshoot so much and you do it end reaming by hand, so it is generally not a problem. Shaver blade is where I had an issue, so I am very much wary of this instrument. Radio frequency, another option you can try, but be very careful. What happens in an arterial injury? First, the biggest problem, how to recognize. Our tendency is spasm hoga, abhi khul jayega, टूटने के टाइम ज़्यादा हो गया, अभी वो limb तो warm है, saturation आ रही है. So our tendency, because rarely ever you have a cold limb. Saturation always comes because it's always a partial injury. You are shaving off or cutting the anterior cortex. The blood in continuity does go. There is some collateral. It rarely ever goes into total off. So you will always have some perfusion, saturation maintained. So be suspicious. First is don't panic. Don't do it at a peripheral center, at a less equipped center. That is where the issue is. You don't have anything at hand, any help, any diagnostic facility, any transport facility in a far off center. That becomes a big issue. So you should have things around. I'm not saying your center should have it, but you should have things around so that you can rush around. if required. I'm lucky to be in Chandigarh. I have big multi-specialties around me, but you should have at least backups around you, if not inside your center. As soon as the artery injury happens, the sudden gush of blood in the posterior compartment for 2 or 3 minutes, then settles reasonably because of the tourniquet. There's not a continuous bleed. This one we need to know. This I discussed with many people and they had a similar experience. Suspect the arterial injury if there is an immediate hemarthrosis after deflating tourniquet. It's a tight, good hemarthrosis in 2 to 3 minutes, 1 or 2 minutes when you deflate the tourniquet. And obviously pulses will not be very well felt. And always overdiagnose. Do not underdiagnose कि ठीक है शायद ठीक ही होगा. Act fast. It is very, very important. Do not take it casually कि we'll wait. No, it's arterial injury. You have to act fast. What to do actually? I discussed with a CTVS friend of mine, then intervention radiologist, last a lot of people. First and foremost thing is pressure dressing. One of my cardiologist friend told me they have femoral artery punctures when they do this PTCS. Many times they have to do it femoral. And it leads to a hematoma at times. There's a leakage from that side. It's pretty similar to what you can compare it to a popliteal artery injury. And their standard technique is to give a high pressure bandage and it settles. It settles down. So more often than not, it is a small rent and it settles down with pressure dressing. At least for the initial, immediately you need to do a pressure dressing with a sponge or something in the popliteal fossa that gives a direct pressure. If possible, shift the patient to a CT scan immediately right from the OT, immediate CT angiography, so that you don't waste that. If you have enough facility that is in nothing like it, shift it to the CT machine, get a CT angio, and you are sure whether it's injury or not. Take a help of an intervention radiologist. They have this stents they can put, even though they're not very successful in this region, in the knee region, but still they have. Or a CTVS consultant, at least involve them, whether do anything or not. And the biggest thing is act fast. Do not sit on it. What to do, act fast. To immediate CTO, immediate talk to patients, relative, and do it. This is something you can save. What's the post-op protocol I follow? One, you have to have a PCL pad. This is indigenous made thing of sponge. I have got another thing that I made with a cover which I fix in a normal brace and push the calf anteriorly. And one thing is in PCL, slow and steady. Do not rush through the post-operative period. Do not try to get that early mobilization. Slow and steady wins the race. 3 months, no weight bearing. At least I do not. I'm really doubtful that anybody else would be getting it done. Non-weight bearing for 3 months is the big thing. Use a PCL brace or a multi-ligament brace. I use a Donja sometimes. Don't be aggressive and counsel patients adequately about this part in the perioperative that they will be non-weight bearing for 3 months. This is the biggest issue. As on ACL, we say we'll make you bearing the next day. And at least we don't counsel for 3 months, then it becomes an issue. And my target is to achieve passive. Passive is the key. Full range of motion and good static quads controlled by 4 to 6 weeks. That's all. If I get this, I'm more than happy. 6 weeks, full range of motion, passive. I'm happy with it. I don't want anything more. Strengthening will be done at a later stage. Complications, arterial injury, infection, technical failures like wrong tunnel placement, missing of other things, missed injuries, or operating in a fixed posterior subluxation disasters. Knee stiffness is the biggest challenge I face in case of PCLs because passive range of motion is not an easy thing to be done at home. So getting the full range of motion is a relatively bigger challenge than other ligament surgeries of the knee. This is a challenge which I do face, but at the end, by the end of 3 months, most of them are happy. Residual laxity is a integral feature in PCL, I would say. Most of these studies and techniques till date have an element of minimal residual laxity, even though it is not troublesome to the patient, but it is there. That is somewhere I find the role of all inside reconstruction better. I feel that the residual laxity has decreased in my patients, or it is virtually eliminated with the use of all inside technique. I feel this is a very difficult thing to actually be sure about. Greetings from my side, Chandigarh. This is the first part of the talk. I have a case report on PCL avulsion for 10 minutes. I'll discuss after this. Maybe if everybody is willing, that's all. Just 10 minutes small PCL avulsion talk. We can discuss about the question and answer, anything we would like to discuss now on this. And then we'll have a small case of PCL avulsion. What do you say, sir?
Yes, sir. We have a question by one of our delegates.
Yes, sir.
So shall I?
Yeah, Jesh, go ahead.
Yes. Yes. So Dr. Sanyam Chauresia, one of our delegates who has joined this online CME, wants to ask that can we fix PCL evolution by screw using arthroscopy? Tips to get proper orientation to apply screw from PM or PL portal. Which one is better, screw
Sayam,
or pull out in PCL evolution?
Same in PCL avulsion, putting a screw arthroscopically doesn't, gets. I cannot visualize it because you have to put a screw from posterior to anterior position, and arthroscopically I cannot put a screw from posterior. I use a suture pull-out technique for arthroscopic fixation of PCL avulsion that I'll demonstrate in the case report. But screw arthroscopically, I'm not aware if that can be put.
It can be put. People have done it. Can I?
Yes, sir. Please.
People have done it. Means they what they put is that they put a retractor.
Okay.
After making a safety incision.
Okay.
And then you can go up to the almost to the center of the screw. But it's a very difficult, and I tell you, I have not done it. I have just read the papers. I have not seen it even. I have not seen it in so many conferences that anybody is putting the screw. And I think the pull-out suture technique has an advantage that whether it is a small fragment or a large fragment, you can use that technique very nicely. And with this, I used to do with the Ethibond, but now with a fiber wire, it is much more secured. And I think everybody should learn that technique. And if you are doing a regular PCL, it is not a difficult technique to do it.
Okay, sir. I prefer fiber tape nowadays. I use it.
Absolutely. It's okay. Fiber wire, fiber tape means anything which is polystyrene, which has a more strength. Can I give my two three my observations and tips to make the surgery better? First thing that I think one you must have 3 2-liter saline bottles.
Yeah.
And it has at a very good height.
Yes.
It should be height variable. Means either you have a pressure system by which you can push the saline inside, or you have a height of around 8 or 10 feet with the 2 saline bottles. And that will really keep the capsule and the other things out from the posterior tibia. And as you have mentioned, that the most important instrument is the tissue elevator.
Yes, sir.
If you do not have tissue elevator, do not operate. And I also feel that what you have said, that your vascular surgeon should be available within 1 hour. Wherever you are operating, the vascular surgeon has to be there within 1 hour. Either you shift the patient or you call the vascular surgeon at your place. But this is very important. And no patient of mine goes out of the theater till my anesthetist put the pulse oximeter on the second toe of the operated limb and tells me that the perfusion is more than 90% or 95%. Yes. And usually, whatever the length, you might have used the once you have deflated the tourniquet, and if you reinflated tourniquet, then also within 5 minutes, the perfusion will come in that limb. Even if you have taken longer time to operate, and I'm sure that the people who are doing regular PCL will vouch this, that within 5 minutes you should get the perfusion in the operated limb. Otherwise, you should suspect a vascular injury. And I have also burnt my fingers. Means I had amputation of my patient. So it's irony, but this is a fact which I am telling you this. So, and I would have loved to Siddharth, you to talk about the passing of the graft.
Okay, sir.
This is one of the most challenging tasks.
What I do for passing of the graft, sir, if it is a all inside PCL, then it is straightforward from within the joint.
I'm sure.
In case it is through the tibia and through the femur, I take the threads from the tibial tunnel, bring them out anteriorly through the portal. I pull the threads anteriorly, and I pass the graft through the tibia. I put a Wisinger rod between the tibial articular surface and the graft, so that I push the graft posteriorly with the Wisinger rod and pull it anteriorly with the threads, so that pulling force changes direction while going to the tibial tunnel. That is how I do it. And once it is passed through the tibial tunnel, then I pass through the femoral. I don't pass in one single shot.
Right. So what I usually do is that I make tibial tunnel 1 millimeter larger.
Okay, sir.
It doesn't make any difference in the long-term results. But when you make 1 millimeter larger than your graft size,
yes,
and I always use the dilator.
Yes, sir.
See that the dilator comes inside the popliteal region when you are having the scope on the posteriorly, and then and with the help of with the help of even simple probe,
yes, sir.
You are able to pull it. The assistant has to be good.
Yes, sir. You have to have a constant assistant for a PCL.
The assistant has to be very good. Yes, in this case, it will be better to have an orthopedic colleague as an assistant.
Yes, sir.
Because that makes the life much more easier. That is what I'm. And how many patients now you are doing actual reconstruction, and how many patients you are doing augmentation?
Sir, essentially it is 90% augmentation.
That is what I'm saying.
90, I would say, but it is like more than 50, 60, 70% augmentations, and hardly 50% is reconstruction, sir.
Have you seen the difference of the result in the achieving the stability in this patient much more earlier than what you are doing total PCL reconstruction? Vade also, I would like to ask.
Sir,
what is
I am pretty happy.
When you are doing augmentation and when you are doing total reconstruction, have you seen difference of achieving faster healing of the graft when you do augmentation as compared to reconstruction?
Yes, when you're doing a partial PCL reconstruction, the healing rate is very high because it is already existing vascular structure, and the healing is always better. So the outcome of partial reconstruction of PCL is far better than the complete total PCL reconstruction.
Right.
I'd like to add a few points on Siddharth's presentation. Siddharth, wonderful presentation, but I feel you made the presentation very scary so that people will not operate a PCL reconstruction in lifetime.
Artery is the only thing I have.
Very essential.
Yeah, I know it is very essential, but thing is that let's not make the surgery so scary that people run away and they will not practice the.
Actually, once you start, it's very enjoyable.
I feel one has to understand the anatomy in great detail. The great say by Dr. John Houston, he said the orthopedic is all about anatomy. 90% of anatomy and 10% of common sense will make you a good orthopedic surgeon.
Yeah.
So the moment you have a complete knowledge of anatomy, the vascular structure, the biomechanics, your job is half done, and what you need is just execution. And you rightly said that the protectors, the instrument which will help you to protect the neurovascular bundle, but most importantly, what is required is creating a space there. You see, there is no space. Yeah. Posteriorly, the capsule is very attached, just close to very PCL on upper side on the femoral condyle. So you don't have a space there. So create a space. The best way to create a space is going transseptal. So what you do is you create an posteromedial portal. I don't use 70-degree scope. I do all my arthroscopy with only 30-degree scope, because 70-degree scope, the most important is creates a blind spot, which is very dangerous in your clinical practice. If you're not used to it by handling blind spot, then you can create more trouble than the benefit. So I use only 30-degree scope, but I keep on changing my portal. I create the first posteromedial portal. Then I go transseptal, create a space behind and around my PCL by reflecting the capsule behind, so that what it does practically, it relieves the connections between the capsule and the vessels, and capsule is floating posteriorly freely so that your vessels are separated apart.
Yes, sir.
So, the beauty of transseptal is you will never have vascular injury because it gives you a tremendous space. You can increase the space almost by 1.5 centimeter. And then
Yes,
you can easily put your instruments in that space. Plus, it gives you additional advantage while passing the graft. Like Dr. Nishit Shah has told you, the passing a graft is a very, very tricky thing in PCL. Sometimes it can give you a complete nightmare.
yes,
I don't agree by drilling 1 millimeter extra, like Nishit Bhai has told you. I do what is perfect match graft because graft healing is very, very critical. But what I do is I can manipulate from both sides, the posterolateral portal as well as the posteromedial portal. The moment I have
you're taking both posterolateral and posteromedial.
Yes. When I do transportal, you have to take both posteromedial and post-portal because now you're transseptal, you're removing the septum. You can go from both sides of the PCL. You can maneuver your instrument. If you want, you think still you are not satisfied. What I do is I take a Foley's catheter, sterile Foley's catheter. I keep posteriorly and inflate it with water. So what it does is pushes your neurovascular bundle still further, and it gives you yes. What is that?
Where you keep the bulb of the catheter?
Yeah, you can keep the bulb of the catheter and inflate it. So what it does is
where exactly do you
below the tibia?
Not below the tibia, below the PCL. So where your PCL, you want space, right? Once you do transseptal, you have adequate space. And if you want another space, what you do is you take the Foley's catheter, you keep
How
it.
many times you do this, Roshan?
What is it?
How many times you do this?
Rarely, but this is one tip when you don't have a
is very
space. Yeah. So like what we used to do in double row rotator cuff tear, whenever we never used to see the lateral side, the subacromial space on the lateral anchor, I used to put my Foley's catheter and inflate it so that it gives me additional space. My deltoid is reflected up, then I can easily pass my anchor there. So these are the few tips which can be used in clinical practice. Mind you, PCL surgery is not that difficult. What you have said, the vascular injury should not.
There is only one fear, that is vascular injury, nothing else. And
that's true. But we can prevent it. See, we operate humerus, we operate anterior tibia, we operate anterior hip approach. They're all vessels. Yeah, in fact, once you start handling vessels, your fear will go away. Dr. Laura Lafosse from France, Annecy. He told us that whenever he has fear, he'll go to anatomy lab and he'll try dissecting the vessels. So your fear goes away.
He is able to do vascular repair by himself.
Yeah. So
how many of us will be able to do vascular repair by our?
Nishit bhai, when you're doing radius ulna, if you cut the radial arteries, many times I have repaired it. क्या बात करता है यार तुम? छोटा मोटा artery repair करने में क्या आता है? So during residency we have done all these things, but I don't want you to do all these things. But nevertheless, you should not create fear amongst the orthopedic surgeons about vessels. Yes, you can tackle it. Yeah, we can tackle it. It is one of the complications. There are many complications which can happen in PCL. PCL surgery, it itself could be a nightmare. Sometimes not able to pass the graft. I have seen with a very eminent surgeon that he was not able to pass the graft, and ultimately he has just abandoned the surgery and kept the graft in the fridge. After 3-4 days. So this can happen, and these are the day-to-day complications. So forget about it. Complications will keep on happening, but PCL is a very, very orgasmic surgery. If I have to describe it, the moment you do it, you feel satisfied. So I'm very sure
you don't do another surgery on that day.
You don't do another surgery on that day.
You really want to relax after that. That something good has happened.
You have achieved something. No, I like your tip of using the K-wire and not the drill tip passing pin.
Yes, that is very important. And in fact, nowadays the drill machines are available which go on not on rotation mode, but they go on the oscillating mode. So the chances of damage to the vessels is very, very less. So technology is there to help you out. Don't.
Which is more risky? Which is the major cause? That is the the tip of the guide wire or the shaver blade? Because my injury happened with shaver blade.
So I will tell you, the shaver blade injury, what will happen is it will rotate and it will create a big rent, and probably that could be
created a 0.8 mm rent.
Yeah. So advisable tip is not to use shaver on posterior side. The best way to use is radio frequency device, RF. Even if you run your radio frequency device on the vessel,
can also damage. Huh?
No, it can damage, but if you press it, they'll damage. If you just touch it, it will never damage. In fact, Laura Lafosse does all his brachial plexus and neurovascular dissection with RF. Low RF, it will not cut beyond 50 micron. So
Right.
unless you press it your the RF onto the vessel, it will not damage. Even if you use RF on
A simple
neurovascular
touch won't cause a damage.
no, it won't cause damage. It is very, very safe. So it's advisable is to use RF whenever you're dissecting the posterior part of. I always do my PCL with RF. I never use shaver in
I've used
posterior
it twice,
compartment.
but I was not very. It was comfortable with it. Maybe next time I'll be more.
Yeah. It is very good. RF is very good. It is a control burning. It never burns. It is a fantastic radio frequency ablation, and it gives you a very controlled dissection. So that is a very big tip. So if you want to avoid neurovascular bundle, don't use shaver. Unless you're a very expert surgeon, you know how to handle the shaver in posterior compartment. Never use shaver for your PCL, the posterior compartment. Best way to
I
use
think
RF.
both portals also make a lot of difference, you know.
Yeah.
Both
Transseptal makes your life very easy.
It's very easy.
And,
Transseptal
yeah,
makes it.
and you can really erase the capsule from the posterior part of the tibia very nicely if you have both the portals. You know, you can even the shaver use becomes more safe, you know, when you have both the portals. I think
See, I think the tip in arthroscopy is visualization. Unless you have a very good visualization, you will never succeed. And as regards to your tourniquet time, it is a mastering the technique. Once you master the technique, I don't think so anything will you cannot go beyond tourniquet time. Usually you can finish the PCL within 45 to 1 hour depending on your skills, but once you master the technique,
it's a multi-ligament scenario which in which you need
multi-ligament also the best way, as you told that you first harvest the graft and then raise the tourniquet. That is one. That is the best way. I usually practice that. In fact, if I have to harvest from the other limb, I always do the harvest and then proceed with the surgery on the surgical side. So I don't waste my tourniquet time. Plus, as Nishit Bhai said, yes, two orthopedic surgeon. In fact, I have a legacy of having a lot of residents in KM, so I allow them to prepare the graft. So I don't waste my time preparing the graft.
Yeah,
I give them
absolutely.
the graft, they prepare it so that I can spend my time on real surgery. So by the time half an hour your graft is ready and you're ready for the graft placement. So the total surgical time will never exceed the tourniquet time, even if you're doing 4 ligaments at one go. So it's a teamwork. In US also they do similar way. I went to certain center in US like Chicago, Brian Coles Institute. They have a complete team. So graft preparation is done by someone else. The surgery is done by someone else. They'll just tell you the diameter. This is 12 mm or 9 mm graft. You just drill it accordingly and place your graft. So it's a complete teamwork whenever you do so complicated surgeries like PCL.
Yeah, and what I would like to add is that even if you release the tourniquet, do you use any something like Disprin or anything after the surgery for a few days?
No, it's not required. See, if you're not damaged vessels, you don't require anything.
Not yet used, sir. Never used.
No.
Okay. So no, that is also because some people they advocate that you should use the blood thinning agents for a few days. And I wanted to ask you, Siddharth, what is your? I was surprised with that because I don't know whether about Roshan, but why you want to keep these patients non-weight bearing? Means with a brace, if you have a good brace, why you want to keep this patient non-weight bearing 3 months? 3 months non-weight bearing is something which doesn't enter my mind, you know.
Sir, if we have the static brace, this the one I showed. In this one, it is basically not a very stable type of situation to get him to bear weight. So,
why? This is a very good brace. It should fit tight, you know, and the tibia should not subluxate backwards, you know. I tell you.
That fear you can see on the mind that it may sublux.
The ligament, if you do augmentation, the ligament will heal at least sufficiently in 1 month. You know, you do not get any laxity after 1 month. You know, most of the patients, if you have done a good job and if you have given this brace. So, what is the reason for non-weight bearing? You know, I'm not able to understand.
Maybe the guidelines or discussions that we have had always points towards non-weight bearing or keeping it off.
Roshan, you?
No. I'll tell you. We had a discussion with Dr. Rob Laprade when he was in Goa last year for the PCL session, and he has said that in his practice he is very aggressive about rehabilitation because he has burnt finger whenever he has gone very slow on rehab, especially with PCL or multi-ligament reconstruction, and he believes in immediate range of motion from next day and immediate quadriceps exercise and weight bearing for single. Yes, what is it?
Passive range of motion.
Active range of motion. Active range of motion in PCL. Yes, yes.
In prone, not in supine.
In prone position, so that you can achieve a good range, because eventually if you don't get good range, the surgery is failure, according to Rob Laprat. So after that meeting, I started mobilizing. Even I was under impression that multi-ligament or PCL should be immobilized for longer duration. But then after that meeting, I stopped doing immobilization. In fact, I stopped using
weight bearing
brace
next
also.
day,
Yeah, and weight bearing as early as possible. He has not categorically said that 2 weeks, but usually within 1 or 2 weeks you start with weight bearing. Yes.
Partial weight bearing, sir?
Partial weight bearing and gradually full weight bearing.
Yeah, with the first with the weight bearing as comfort of the patient,
Okay.
Yeah, and it improves the proprioception also. Most importantly,
definitely.
if you don't,
proprioception is better.
Yeah, if you don't weight bear, you'll never develop that proprioception. So patient has to walk as early as possible.
And Roshan, when you do manipulation and anesthesia after surgery, if required,
Manipulation for what?
Yeah, for stiffness.
So I think prevention of stiffness is more important than manipulation. Manipulation should be avoided. The moment you do manipulation, there is a high risk that patient will have other problems like the patellofemoral arthritis and other tissue issues. So I feel as far as possible, try to avoid manipulation.
So my take on manipulation is that I never manipulate independently. If at all, I have done 2 or 3 cases arthrolysis. I do a arthroscopic arthrolysis complete, and in the end I manipulate. I never per se manipulate, because the book says that you manipulate, you end up with more fibrosis in the long run. That is what I have practiced till now. Never done isolated.
Siddharth, when you will do arthroscopic arthrolysis?
Sir, I have done it 2 times in ACL, never in a PCL. In one patient I did at 6 months, and one patient I did at 8 months.
No, I'm talking about PCL. I am not talking about ACL.
PCL, I have never had a range of motion less than 1.
Even I never did any manipulation for my PCL.
PCLs, because we are very particular about range of motion. PCLs, we are very much counseling all the time. ACL sometimes are, get casual, get lost to follow up. PCLs,
usually what happens is PCL patients are chronic patients, and they come with a very good range and very good quadriceps. In fact, they are completely quadriceps dependent. So the recovery of PCL as far as rehab is concerned is very fast as regards to ACL. If you slow down that recovery in the form of brace and not allowing weight bearing, then you will have stiffness. So I feel most important.
Next time I'll be aggressive. I never thought in those lines. Next time I'll be aggressive with the rehab. Let's see what happens.
So you have to be aggressive. I mean, after 2-3 days, they can start prone bending. And I ask wife or husband, because they want to take away, they want to do the revenge of the things that each of other has done on. So they do very nice. You don't need a physiotherapist for a few days.
Sir, we have a few questions that I think we needed to just pick up one by one. One is a role of osteotomy in chronic PCL insufficiency. This is Nitin Bittar asking. Sir, role of osteotomy, HT or tibia slope change or combination?
Yeah.
Nitin, for
so
this,
when,
if there is a varus tibia, basically varus deformity, then we need to consider osteotomy. Otherwise, a simple well-aligned limb, the osteotomy really doesn't suit in well. So what do you say?
So I think whenever you're dealing with PCL, the most important thing is knowing the alignment. In fact, that is the algorithm of PCL management. The moment you have a very good alignment along with grade 3 PCL instability is our ideal indication. If your alignment is little bit varus, the indications for PCL reconstruction will change. And the best way is to do high tibial osteotomy, the medial open wedge high tibial osteotomy, so that you can correct the posterior tibial slope, and you are not required to do any PCL reconstruction. So you can open the wedge differentially, maybe posteriorly more and anteriorly less, so that you can get a good wedge shape.
The tibial slope is also corrected.
Yeah, so posterior slope is corrected, and you will never require to do any PCL reconstruction if you do a good osteotomy, medial open wedge osteotomy.
Sir, another
This
question.
will also take care of the posterolateral corner laxity,
Corner
and that
laxity.
is also very important. So, but the thing is that the clinical examination, the patient should have a medial joint line tenderness
Yes, sir.
and little bit of varus. You know, if you don't, and of course the scanogram, full length scanogram is absolutely a must before embarking on this. And even a young patient, the osteotomy gives a very good result. And I think that is always to be in the armamentarium. So don't jump on the only PCL reconstruction. I think the osteotomy should be, and in this country, the patients are very happy with osteotomy results, you know, because they can sit cross-legged, they can sit on the ground, and unless and even if we have told them not to do it, they always do it.
Yes.
Yeah.
Sir, one question. What do we consider whether open screw fixation is better or arthroscopic pullout is better for PCL avulsions? What's the opinion?
PCL avulsion is a very different ball game. If you have a big fragment which is bigger, good enough to be fixed with the help of the screw, is better to take a posterior Buck-Schaffer approach and do open fixation of the ligament, and that's possible. We can use the spike washer, or you can use any other technique which will give you a good fixation. When it comes to a very small fragment and a very little bit smaller fragment which cannot be held with a single screw, then it's better to do an arthroscopic pull-out technique, which can be either single row or double row pull-out technique. The simple thing is create a tunnel, pass your thread all around the fragment, and just pull it out so that it fixes on the posterior part of the tibia. So these are the two different ways you can approach the PCL avulsion: the big fragment and small fragment.
Well described, sir. About the choice of graft, sir, my choice remains in case of multi-ligament, I prefer peroneus longus, maybe add-on gracilis for PCL and the semi-T for the ACL or the other ligament. That is what I prefer. What about the choice of the graft for the...
Yeah, so I like to use quadriceps tendon for my PCL. Even if it is isolated PCL, I believe that that will give me adequate length. That is one. Secondly, it is very easy to recover muscle. Peroneus longus especially is very difficult in athlete. If it is a non-athletic population, you can use peroneus longus, but if it is an athlete, you have to use something which is very good graft, and that is a quadriceps.
Take a bone plug?
What is that?
Bone without
bone plug.
With the bone plug, always with the bone plug. So that gives me adequate stability, and the graft size is very good as required for PCL. When we are doing a multi-ligament, yes, I do other way around. I go the hamstrings for my ACL, the other side hamstrings for my collateral, the peroneus longus for PCL, and quadriceps if required for either ACL or PCL, depending on
you
the
do
graft choice.
quadriceps from the same side in PCL or the opposite side?
No, same side.
Same side.
Yes,
And
same side.
bone plug goes into femur or into tibia?
You can put it in tibia. The best way is to put it in tibia. You want good healing on the tibial side. In fact, you can go up to the mouth of the tibial tunnel on the posterior side, and you can fix it with the screw. On femoral side, you can do it with only bias screw.
You do not take a bone plug if you, and then the bone plug is very small. Otherwise, you can be done without quadriceps tendon can be done. My choice is bone patella bone with multi ligament for ACL, and for augmentation of PCL, I will always take a quadriceps. And if I have to do third one, then probably opposite hamstring or peroneus longus. But I don't like peroneus. I do not use peroneus longus that much now.
Okay. So any specific reason for not using apart from athlete population, normal population, peroneus?
We use it very regularly in revision ACL, the multi-ligament, the peroneus longus. But athletic population, because it's the most important inverter of the foot, is better to be avoided because they want to play, they want to run. It's very difficult to get a similar kind of.
He's decreased his usage. Is there any specific reason for decreasing the use of peroneus longus? Dr. Nishit has decreased.
Achha, Dr. Nishit, okay.
Yeah. The thing is that I was in discussion with Salim Parekh, who is the ankle guy in Dukes, and he said that because the peroneus goes up to the second toe, once you remove it, then gradually the patient that start developing flat feet or problems with the forefoot in the long run. This is the possibility is. As Roshan has said, then for revision it is okay, but not in primary ligament reconstruction. I would prefer to do because we have a lot of both quadriceps, both bone patella bone, both hamstrings. So six grafts are already available to you to do primary. So why you want to sacrifice one of the most important inverter of the ankle?
Okay. Sir, how many patients feel encounter patient? I think we are done with most of the questions. The rest are individual queries. We'll just go have a quick shot through the PCL version and then then finish it off. We have just 15 minutes left, sir. So we'll just finish it off quick. The PCL version. Are we good to go, sir?
Yeah. Go.
Just a small short case. Yes, start, slideshow. Visible? Is it visible? The screen is visible, sir? PC. Jayesh?
Yes, sir, it is visible. PCL evolution. Yes.
Version of arthroscopic fixation. This technique was the courtesy of Dr. Sheetal from Bhopal. I learned from him. So this is a case of PCL version. This is the CT films. So we can see a very clear-cut fragment of the PCL which is seen there. And you can say a smaller piece in the definition as Dr. Roshan was describing. This
Dr.
is the
Siddharth, you need to swap the images. We are getting a small for your... Yeah, that's fine.
This is okay? Hello?
This is okay. It comes very nice. That is okay.
Okay, now this is the MRI image. We can see this is a reasonable piece of the PCL here. So this is what I did. I did a transseptal portal. 3 portals on the front, 1, 2, and 3, and 2 on the back. Significant number of portals, I would say 5 portals. These are telltale signs of the acute injury we can see here, the abrasions. And this is the PCL fragment going here. I know it's a bit bloody, not so good looking, but this is the PCL piece. This is the posterior portal, the cannula and the shaver directed towards the femoral condyle and the tibial condyle, clearing up the area. This is the jig coming. This is the PCL tibial jig, which has made the fragment sit down on the bone. This is the mirror image actually. Basically, this is from the other side portal. So it looks like a mirror image. So this is the jig which is making it sit down. And this is the guide wire which is passing through the fragment. This is the PCL. This is the bony fragment. And this guide wire is coming through the fragment. Over this, we do a 4.5 mm drill bit. That is the standard endobutton drill bit. And then I pass a loop of thread from there. I don't have the proper image. I pass a loop of thread from here and take it out from the back, put a suture washer in that loop. I take a suture washer which is coming from the posterior portal, entangled with a loop of thread.
What is the size of the suture loop? The
suture washer.
Washer?
So it's a standard suture washer. So the standard 8 mm, I think 8 mm suture disc of Biotech, that is what I use for this. A round hole one. A round hole suture disc I use, and I think it's 8 mm only if I'm not sure. 8 mm or 10 mm suture disc. I use it in a concave down direction and push it on the fragment. This is a small bony piece. Washer face is pushing that and it is being pulled here. The threads are being pulled here, and there is the last image. I think I have missed the image. There's another washer which is tied up. Basically, we have washer here, we have washer here, and we tie them together with a thread. So it creates a pressure across the fragment, and it creates a tension band-like effect for the PCL avulsion. This is, you can say, suture pull-out technique that I'm using. Just additionally, there's a suture washer which is pushing on the fragment completely, so it sits pretty on the bony bed. That is what
Okay.
Yes, sir.
Very good.
This is a small technique, but very effective one. I've had like 11 or 12 cases with this, and pretty happy with this. Like I mobilize them early, make them bear weight by full weight bearing by the end of 1.5 months. And this is where I'm feel very comfortable with this technique. Now I'm using fiber tape. Previously I was using fiber wire to connect the two washers.
Yeah, but so it's very surprising that when you do a pull-out technique,
Yes, sir.
You will when you take a post-operative X-ray after 1 month, 1.5 months, the fragment will be there only.
Yes, sir.
Where it was before, but there will not be any laxity. So I think that the PCL heals even with the fragment, and after 2-3 years, that fragment will disappear.
Okay.
That is what I have marked in 1 or 2 of my patients. And second thing that I personally feel that when you see PCL avulsion on X-ray, means that fragment has come at least from 10 millimeter below the joint line.
Yes, sir.
So there is no conservative management.
Yes, sir.
When you see a fragment which is at the tibial joint line.
Yes, sir.
This has to be fixed, and you cannot, otherwise this patient is going to have a PCL laxity or posterior translation of tibia, and that will fix posterior capsular contracture in the long run, which is more damaging to the patient than doing a PCL surgery in initial stage.
Exactly, sir. Sir, what is your cutoff for like fixing a avulsion of PCL cutoff? Arthroscopic fixation and open fixation. Like when
I do not do open fixation in any case.
So
I do
1 month.
Usually,
one month.
beyond...
Yes, no, 1 month. Even after 3 months, what I do is I take a fraction extension view. If the fragment is moving,
yes, sir.
Okay, and if I feel, of course, clinically there will be laxity, and the fragment is moving around at 1 month, then what I'll do very nice release from the behind.
Okay.
I will see that the fibrosis is removed between the fragment and the tibia, posterior tibia.
Okay.
I will also use my jig to make multiple holes in the posterior tibia where the fragment is going to get attached.
Okay.
And then I take a pull out sutures. I make a bleeding bed if it's a chronic avulsion, and then take a pull out suture and put it back at its place.
I think 3 months. 3 months is a time beyond which it's very difficult to get that fragment healed back. It's
actually I'm doing a PCL 3 months old, so I try to fix it, but ended up doing a reconstruction.
It's better to reconstruction rather than repair of that fragment. It's very difficult.
Absolutely. I tried repair, and then I left it and did a reconstruction.
Secondly, about your technique of PCL avulsion, what you have shown, rather than putting that metallic button behind, it's better to create a suture bridge. Like, you can...
yes, sir.
Hello. It's better to create a suture bridge which will give you an adequate fixation of the fragment onto the posterior aspect of tibia. When you put any kind of metallic device, it's very difficult to remove that. The revision surgery could be very, very difficult. And secondly, it leads to a severe adhesions, and so that it makes your life miserable if you have to revise it. So I feel simple sutures which are commercially available, high tensile sutures which will give you adequate strength to fix that fragment on the posterior aspect. You can create a double row type of fixation. Either you can create a single row type of fixation which can give you adequate fixation.
Okay. So we'll have
and also when it is very easy to say that it is not very easy to pass the wire through the fragment,
Yeah.
Because
passing wire through the fragment it's like bullseye aiming. It's very difficult.
Yeah.
Plus, there is a chance
and you don't know whether it was a comminuted fragment or not in between, because the X-ray
it's very difficult. Advisable is simple pull-out technique with multiple holes. You can create 2 holes posteriorly so that you can get adequate strength of fixation on the both sides. So you
And you
can
don't have to
have
use any implant.
lateral side and medial side of the fragment, create a good pull out strength, and then fix it.
And how do you
And
pass
no,
the
you
thread
don't need
through
any
the
implant
PCL?
even. Even you
What
can
is
do it
that?
without implant.
Yeah, we can you can do it without implant. You can just
Yeah.
fix it from the anteriorly on the bone bridge
Yeah. So
between
Yes,
two
absolutely.
tunnels.
how do you pass the suture through the PCL ligament? That is through a acupass or something?
Go all around ligament. So you have to create intra-articularly. You have to create three windows. One between PCL and the medial femoral condyle. The other between the PCL and ACL, and third is between ACL and ACL and lateral femoral condyle. So when you create these three windows, you can count with your PCL fragment. Then you go all around the PCL with the high strength suture material, and then pull out both this from behind.
You go around it or through the PCL substance?
No, go all around it. Tie a
All
knot on
around,
it.
all around. There is actually, you know, this is a good technique. But even if you go from the anterior portal, just put two different color sutures through the stump of the PCL and just pull it out on the back and bring it on in the front. Then this also is sufficient. You know, what Roshan is describing is very good, but sometimes very difficult, especially the lateral window.
Rotating around. Maybe we'll try it next time.
Yeah. See, I'll tell you, the Dinshaw has presented the same paper for in Issaquah's John Joyce Award. In fact, he has won the award on that.
He has a video on ViewMedi also for that.
Yeah, it's a very good and very easy technique. You have to create post-immediate portal. Use a knot pusher.
No, but what he puts a multiple knots, right?
Yeah, you have to put multiple knots so that it gives on pressure. In fact, we go other way around. What I do is I create an anterior tunnel also in front of PCL. I create two tunnels posteriorly also, just beneath. So, in fact, it is what Dinshaw does is a single row repair. When you have a deflection, it might come out. So, I do double row. Double row in the sense I do one tunnel very anteriorly, then two tunnels very posteriorly. My thread will go here, go on this side, then one thread will go here and go on this side. So as to pull my fragment completely, that fragment will be completely held up.
Okay.
There are many techniques which have been described. It's the same way we do nowadays on ACL also. We create 2 or 3 tunnels for ACL avulsion, then go around it, go around ACL, take a bite
and
with the help of the spectrum.
It will be good bleeding bone, you know.
Yeah.
More multiple tunnels, good bleeding bone, better healing.
Yes, better healing, and it gives you adequate stability, and you don't need any implant. That is very important because removing that implant is very difficult.
No, I entirely agree with you that if you don't put something in the
after
area, it is better.
After the invent of fiber tape and ultra tape, the job is very easy. You can get a solid fixation. The strength of fixation is very, very high.
Take, sir.
Thank you.
Okay.
Thank you very much. It was a wonderful
meeting. Thank you, Dr. Roshan.
Thank you.
Fantastic meetings. Learned a lot of things.
You're going to put this on ViewMedi or
I'll put it.
YouTube? Okay. Thank you.
I'll put it on my YouTube, and I think I'll put it on ViewMedi also. That I'll take guidance from you, sir.
Yeah. Thanks. Bye.
Thank you.
Thank you, Roshan. It was nice seeing you also.
Nice seeing you, Nishit. Bye. Thank you.
Yeah. Okay. Bye.
Sir, one or two questions are left. I just finished them.
Before we end,
yes.
Sir, are you continuing or we can take over?
One question is last from Indradeep. What if the fragment is comminuted for PCL avulsion? I think Dr. Roshan has answered this to use a suture technique. That is all, I think. That is where it is. Yeah. Jayesh, you can conclude, please.
Yes. So I'd just like to thank Dr. Siddharth Agarwal for delivering an informative and thought-provoking lecture as a guest speaker on PCL deficient knee and its evaluation and management. And further on, I would like to ask Ranjit sir, our national sales manager, who is also present here, to give his thoughts on this. Over to you, Ranjit sir.
Thanks, sir. Good afternoon to all. On behalf of Alembic Pharmaceutical, I would like to thank all the delegates who took their time and be the part of this knowledge sharing experience. I hope this session was quite informative, and especially I would like to thank Dr. Roshan Wade sir, Dr. Nishit Shah sir to make this session very, very interactive. and it will be very, very useful for all other delegates. I would like to thank Dr. Siddharth Agrawal, sir, who has really taken the time to make this detailed presentation on PCL knee injury. So, and we are very much interested, and we will be very happy to arrange many such more programs in the coming future also. So thank you very much, sir. Have a nice day.
Thank you very much. Thank you very much for your support. I think Siddharth, you did a fantastic.
Thank you, sir. Thank you.
Okay. Have a nice day. Stay safe.
Okay, sir. Jayesh, are you there?
Yeah. Yes, sir.
Jayesh,
Yes,
there
yes.
is Dr. Sandeep there. I would like to connect to him. Is he there still?
Doctor?
Sandeep,
So can you please spell?
there are a few questions he had. I just wanted to get connected with him.
No, sir. Dr. Sandeep Devre is not there, sir.
Okay. So just try if you can get me his number later on. Okay.
Yes, sir. Definitely, we will try and get you his
I
number.
think
we
I
could
think he
not
left.
actually get through. Thank you, Jayesh. I think we can conclude, and thanks for winding up. Thanks
Yes.
for everybody.
Thank you so
joining.
much, sir, for giving
Yeah.
us an opportunity. It was informative session.
Okay.
Thank you very much, sir.
Thank you, sir.
Great session.
Thank you. Thank you, sir.